Hello, and welcome again to the Emergency Medicine Clinics podcast. I'm Colleen Dietzler, the managing editor of Emergency Medicine Clinics here at Elsevier. Emergency Medicine Clinics is a quarterly publication consisting of review articles focused on a central topic. Today, we will be discussing a recent issue titled Damage Control: Advances in Trauma Resuscitation. Joining us today are the guest editors of this issue, Dr. Christopher Hicks and Dr. Andrew Petrosoniak. Dr. Hicks and Dr. Petrosoniak, thank you so much for being with us today. Let's start off with the first article in your issue on the human factor in optimizing trauma team performance. Could you give us some background and elaborate on team performance and managing complexity in clinical environments?
Yeah, I think the article kind of speaks to, I think, a broader issue in medical education training, in that I think we've, for a long time, made a fairly faulty assumption that people learn to work both as team leaders and team members in complex environments just by a matter of experience and exposure and osmosis. In other words, team-based skills, whether that's individual or within a group, or learning to work within one's practice environment, are somehow innate. And I think the article is expressing pretty deliberately that those aren't true, that those are all skills that need to be identified and named and practiced and rehearsed, just like learning to put in a chest tube or intubating. And I think this has been a pet peeve of Andrew and me for a long time. And the article kind of gets into, in four sort of stages, the domains in which I think we need to identify and develop skills so that teams function a bit more smoothly. And of course, all of this is much more, it's relevant to healthcare teams and medicine in general, but in particular to something like the trauma environment, where it's very time dependent, that you're quite typically dealing with critical illness, you're dealing with time dependent interventions, whether those are procedural or relate to decision making. The teams are very often ad hoc, meaning it is quite different if you have a team that's been working together for 6 months versus a team that just has to assemble and start doing stuff. And it's multidisciplinary, so you have not only different medical professions, but also nursing and respiratory therapy and X-ray and all of these other groups that have their own backgrounds and their own cultures and their own agendas. And I don't mean agendas in a bad way. Everyone has their own perspective. And again, we've made this kind of bizarre assumption that all of these professionals are just going to be able to arrive on scene during a high-stress situation and be able to function effectively and make good decisions. And so the article starts off with that quotation, trauma is easy, trauma teams are hard. I said anonymous, but really that's been my saying for a while, because the disease of trauma is not, I don't mean to say it's not hard, but when you ask somebody to describe what a trauma resuscitation looks like, most people with training can do so, but making that work within a dynamic team environment, from my perspective, has always been the real challenge of trauma care.
I see that you've included a case in the article about an urban emergency department. Can you walk us through that case a bit?
The article describes a case, it's a made-up case, but it describes a case that is not unusual in the trauma environment at all, in terms of the nature of the presentation and, more problematically, the nature of the team dynamics that follow. The fact that there's a critically ill patient who's pre-arrest arriving and presumably bleeding, who has an airway issue, none of that is unusual. And again, if you ask people to sit down and say in words how they'd manage that, most people could do it. But again, problematically, the scenario that unfolds where people miskey information and sign over, so they don't get all the data they need because there's no standardized process and nobody's listening and everyone's stressed. There's disagreement about how to move forward. There are observations that are made that are not effectively communicated. team leader, and there's ambiguity about who's in charge anyway, and so who's making decisions and who should listen. And so this thing that is not simple but should play out in a fairly straightforward and stepwise way becomes chaotic and disorganized, and in the end, this made-up patient outcome suffers as a result. And again, I think we can all reflect, Andrew and I in particular, on our practice and realize that this is something that happens. It's something that's common. And what's missing is, well, again, 4 parts as the article outlines. So the first bit that the paper gets into is really understanding people's appraisal of stress and how to apply a specific skill set in a stressful situation to get a handle on your acute stress response, to bring it under control, and then to bring you into a somewhat calmer state of focus such that you can execute the knowledge that's already in your head and make it work within a team environment. And that's all stuff just borrowed from cognitive psychology and other high-stakes domains like athletics and military, musical performance, and we're just inserting them descriptively and also experimentally into this environment. And then the second bit relates to then once you've kind of got your own house in order, so to speak, how you make that work within a team. And there's lots of stuff you can say about that. We chose to focus specifically on the communication bits because that invariably becomes a major issue when things get a little bit chaotic. So how to control the room, how to pick your phrases so that, they have meaning and substance, how to escalate a level of concern if you feel that you have an issue that's not being heard. And again, how to synthesize that in a time-dependent way and in an interprofessional environment where you have different professionals with different backgrounds and different knowledge base. And of course, that's not enough, and this is where I'll throw it over to Andrew. You don't exist as an individual and as a team within a bubble. You have to work somewhere. You have to work in a place, in a resuscitation environment. And perhaps the additional madness that we've observed in terms of resuscitation care is that we've given very little thought to making our environment work for us. In fact, the environment just seems to kind of happen, and then teams are forced to adapt and work within it, often with major constraints. But I'll let Andrew take it from there.
Yeah, so as Chris mentioned, we, in the paper, divided up this whole approach to team training in 4 main areas. And while we focus often on the individuals and the teams, we do that sometimes at the expense of the environment that those teams operate in. And there's emerging literature now around the importance of a systems-based outlook on how teams operate. And that really speaks to teams have to operate in an environment. And in this case, it's a trauma resuscitation environment. And we can probably, at least we propose, that should be at least studied, understand that the environment and the role the environment plays on team performance, and perhaps optimize that environment, looking at the way that clinical logistics and what we call resuscitation ergonomics work. We think that if you're deliberate about how you set up your space, if you're deliberate about thinking about the skills and the procedures that are required, and understand from what we call, an end user or essentially the clinician perspective, then you can make the space work far better for you and overcome many of these latent safety threats or things, potential harms to the patient that are not easily recognizable. And so by improving your design and being cognizant of where there might be challenges, we can deliver better care. And we sort of approach this in 3-tiered process, or I guess we refer to it as a 3-pronged approach. But we talk about designing the space and positioning people and deciding where people are going to be well before the resuscitation happens. And then we talk about immediately before, and that's sort of how we might organize the team just shortly before the patient arrives, and then understand how we're going to deal with the space in real time. And we discuss this kind of concept of a logistics and safety officer, where somebody is overseeing not just the way the team is running, but also making sure that the team themselves are safe, and as well making sure that the patient is safe. And it's not just about making sure that the chest tube goes in, it's about, hey, have we set up the chest tube in a way that's going to optimize success for that procedure? And we think that that's something that we probably don't do well enough, and it speaks to the importance of crowd control, noise control, patient positioning, all of these things that we can probably be a bit more aware of and be deliberate with, and hopefully result in better outcomes. We then sort of transition and speak to how we can optimize the system better, and we focus a lot on where problems occur and how to fix the problem. And that's kind of how we deal with things in medicine. We have the concept of M&M rounds, where we identify a problem after it's occurred and then try and fix it. In some of the new high reliability organization literature, this has been kind of put to the side. It doesn't mean that we don't address problems, but the vast majority of the time things go okay. So what is happening in the vast majority of the time that allows for things to work well? And it's this idea of building resilience and building a system that is resilient, and this concept of safety too, where you're really trying to study and promote the system's ability to succeed rather than studying where the system fails. And if you can really build up the system to always work well, then you'll be in a good situation. So for this case that we sort of presented and used, we talk about the respiratory therapist identifying that the patient's without a pulse. And if you had a clinical logistics officer, this would be something that, would not be just one of the random team members identifying perhaps several minutes too late. You have somebody dedicated to the safety of the patient and the team. You would, when you're talking about setting up the environment properly, you wouldn't have this occurrence where the providers, the clinicians, are given a kit they're not familiar with, because you've spent time ahead of time looking at what kits you're going to put in place for the cricothyroidotomy that you're going to perform, and you've optimized the usability and all of that, so that this is not a new thing. And then when you go and may have deliberate training to sort of promote high-level performance.
Thank you so much for your insights. Any final thoughts on this article before we move on to some other topics in the issue?
I would say that a lot of what we said, I think, sounds terrific, and in theory makes a lot of sense. But I think what we wanted to do, speaking specifically to the in-clinics audience, was to try and make it practical. I would say that, particularly when it comes to environmental design and system design, we suffer in healthcare from a real sense of learned helplessness. That is to say that we just accept that our work environment is chaotic and disorganized and not set up, as Andrew said, for success in any given procedure or situation. And we just learned to make that work, which I think is a little bit sad. So rather than simply just state that, which I think a lot of people may have come to recognize in their practice, each section is set up with a description of the problem and the kind of the theory behind it. But then what follows then are some practical suggestions on what you can do. So each chunk of the article says, okay, so here's how acute stress impacts your performance, and this is a theory. But practically speaking, what could you do tomorrow to influence that? Or yes, environmental design is a problem, and here's the sort of 3 steps we think that you can take to alter it. And then practically speaking, what you might do in your practice environment tomorrow to improve upon that. So the article is meant to combine something that is typically a little bit theoretical and heady with descriptions of practical tips for solutions for solving the problem.
Let's move on to the next article on reanimating patients after cardiac arrest. So this article describes a practical, evidence-based approach. Can you talk a bit about this practical approach and the 5 principles cited by the authors?
First, I have to say the authors on this paper, it was a team led by John Sherbino, who's a colleague of ours at McMaster. We went to them with a very specific question about traumatic cardiac arrest, or TCA. There are lots of algorithms out there, sometimes conflicting algorithms, that describe how to manage a traumatic cardiac arrest, whether it's blunt or penetrating or mixed. That's not the challenge. And again, most people can spit out, whether from memory or by reference, what a TCA algorithm looks like. The challenge that we went to Dr. Sherbino and his team with was, we know all that, but we still can't do it in practice. What makes it so hard to do it in practice? And could you describe to us not just the evidence in terms of what needs to be done, but a practical and implementable approach, and this is where you speak of the 5 domains, something that you could actually implement in clinical practice in a situation like this, which is the ultimate in a time-dependent, time-constrained scenario where, it's one of the few in trauma where seconds really do matter in terms of your decision-making. So they came back to us with an article that I thought was really quite brilliant in terms of how it approached the problem. And they talked, again, about 5 domains that don't necessarily have to happen in any particular sequence. And I think that's one of the key elements of what they're describing. They acknowledge that people don't think in algorithms. Sometimes they do, but in a situation like this, your mind just doesn't work step 1 to step 2 to step 3. It just doesn't work that way. And in a disease as dynamic as traumatic cardiac arrest, you probably shouldn't be really scripted. You should allow for some sort of dynamic adaptation or naturalistic decision-making, as Dr. Sherbino would probably describe it. And I think what came out of that article in the end then was a very usable description of the evidence for traumatic arrest management, as opposed to just, well, here's the algorithm, take a look at it and memorize it, because practically speaking, that just doesn't work.
I mean, I think that was one of the really nice things that the authors have provided us here, acknowledging exactly what Chris said, that things do not happen. We never think in an algorithm. We memorize approaches in an algorithmic fashion, but it doesn't translate easily when you're at the bedside. And so what they really tried to do was give the clinician, and this is what we were really trying to impart on our authors when we invited them to participate in writing for the clinics, is we want to give readers practical approaches to caring for trauma patients. It can be overwhelming caring for these patients, given the diagnostic uncertainty, the obvious clear potential for death. And they came back to us with what we think are really well laid out and practical approaches. Dr. Sherbino and his team developed these 5 principles where really the first one, and they acknowledge that this can be altered at any time in terms of which principle you're going to be considering depending on where you are in your resuscitation. But really the first thing that they talked about is whether you should initiate or continue resuscitation based on the prognostic factors that exist and are well described in the literature regarding success in traumatic cardiac arrest. Then they also discuss the lack of utility in chest compressions in these cases. They really focus on fixing ventilation, optimizing the physiology, and stopping the bleeding. So what they have done is that they've given the reader 5 key areas to be considering during the traumatic cardiac arrest, and they've done it in a way that makes sense, hopefully, for how people actually think, rather than trying to memorize an algorithm.
If I could pick up on the bit about chest compressions, I think if somebody reading the article who maybe is not familiar with that principle, that's going to be the one that they may be struggle the most with or have the most questions about. And it's probably quite practice changing, or it will be quite practice changing for many people who are looking at this concept for the first time. And it does speak to quite a change in philosophy of cardiac arrest management. And it also speaks to the broader issue of how we erroneously import concepts from medical cardiac arrest into traumatic cardiac arrest when they are very different species altogether. And so in a medical cardiac arrest, you have a sick heart and you try and make that heart beat better by pushing on it and slamming in epinephrine, which even in medical arrest is of dubious benefit. Neither of those things apply in a trauma arrest. And pushing on a heart that's either completely empty or is working against some sort of obstructive form of shock, like a tension pneumothorax, pericardial tamponade, is just not effective. And in addition to that, the chest is a very important bit of real estate in the trauma arrest in terms of doing ultrasounds, doing chest tubes, doing thoracotomy. And I can remember as a resident doing thoracotomies while chest compressions were in progress, which is extremely dangerous and makes the procedure a lot harder to do. So the theory that you would just stop compressions, I think that's not the sort of thing you can do without any sort of discussion with your team. It's not the sort of thing that people, I think, are just going to start to do in practice. And to be honest, probably something that many people may not be comfortable with initially, but I think it's worth listening to the argument that they make in the article about why that's relevant, under what circumstances you should consider discontinuing CPR. And importantly, it's worth recognizing that discontinuing CPR in a medical arrest means terminating the arrest. And that's not what they're saying here. They're saying stop CPR so that your resuscitation can become more effective. And I think if anyone's going to, if there's sort of a hard-hitting message coming from that paper, that's going to be the one that jumps out at readers.
Yeah, and I think what Chris touched on about ensuring that your team is on board with this sort of shift in paradigm speaks to some of the concepts that we just discussed in the initial paper, the human factor paper. How important it is to get your team on board right at the very beginning, develop that shared mental model and outline some of those strategies that can ensure that the entire team understands what the approach is. Because as he's mentioned, in this type of instance, the utility of CPR really is not particularly valuable, and in fact may actually cause more harm. It may delay critical procedures, and that's what Charbonneau and his team have outlined here, is that really there's probably a few other things that are more important, like ensuring that the patient gets intubated, ensuring that chest is decompressed, and then moving ultimately to a thoracotomy when indicated, rather than putting clinicians at risk with scalpels near their hands when they're performing CPR.
Sounds like a really critical article by Dr. Charbonneau and his team. In the interest of time, let's move on to an article you both wrote called Resuscitation Resequenced, A Rational Approach to Patients with Trauma and Shock. Could you expand on this article and give us some of the key takeaways?
I think over the last 30 or 40 years, since as trauma care has evolved, it really has come from ATLS, which has been a really solid structure for translating how trauma care is provided. And it's borrowed somewhat from the way that we provide medical care during critical situations, the ABC approach, and we've tacked on the D, which for disability, and E for environmental considerations. And we use this ABCD approach on a regular basis to kind of operationalize how we care for patients. And whether it's intended or not, when you lay things out in a sequence like that, the first thing that people gravitate to is ensuring that the airway is secure, and then we'll move on to the breathing, and then move on to the circulation, and so on and so forth. That works out fine in many instances. However, in trauma care, that's often not the biggest problem. The vast majority of these patients are bleeding, and you have to wait until you get to C, or circulation, before you address that. And so when Chris and I were coming up with this idea, and we've seen this ourselves when we watch in the trauma bay at our institution, and we've been a part of it certainly, that oftentimes the airway gets prioritized ahead of what we think are more critical interventions. And actually, not only is this a problem because we think that things should be resequenced, the reason they should be resequenced is because of the potential harm that can come to patients by dealing with the airway ahead of time. And what we do is we provide a case here that we think outlines a little bit about the importance of looking at the physiologic priorities that are important in these instances and not being so algorithmic and following the ABC approach proposed by the ATLS paradigm. And we acknowledge that when you first see a trauma patient, if there is sort of impending airway compromise that cannot be dealt with in any other way other than a definitive airway, then that might have to happen immediately in instances where the patient's critically desaturating or you think that you're going to lose the airway, in which case you have to intervene immediately. But what we're really trying to impart upon readers is the importance of optimizing the breathing and the blood pressure so that when you proceed with airway interventions, that you won't cause harm by changing the physiology of the patient once the patient gets intubated and potentially harming them when they decompensate if there's occult or underlying shock that maybe wasn't recognized. So we really have adjusted how we approach these patients. We've deprioritized airway with the exception of providing as minimal intervention as needed. Most patients, when they come in the door, don't need to be intubated on arrival. In fact, they respond quite well to oxygen, suction, jaw thrust, that sort of thing. And then the focus can be on control of any massive external hemorrhage, resuscitation, and then return to definitive management of the airway and doing so in a safe fashion. And one of the critical things that we think also happens, and what we tried to impart, was once you've made the decision to intubate, the importance of when you're proceeding with an RSI, which is sort of what we advocate as in the vast majority of cases, in these shocked patients, the importance of dropping the dose of the induction agent while maintaining a full paralytic dose. And we've seen this happen time and time again in our institution where that hasn't where people don't follow that advice and the patient suffers hypotension or cardiac arrest. Chris, anything to add on that?
No, I think the key point Andrew already touched on, which is it's not like we are not suggesting that airway and oxygenation and ventilation don't matter in trauma. But more so, I think the key is what Andrew already pointed out, which is resuscitation in all circumstances, trauma is just one of them, needs to be focused on the physiologic priorities. And sometimes that's immediate airway management with intubation, but often it isn't. And much more often it's addressing issues related to shock in its various forms. Sometimes it's neuroresuscitation. Sometimes it's managing an agitated patient who's posing a danger to themselves and to your team. The priorities, those priorities, I think, need to be considered in each and every circumstance and kind of taken on a case-by-case basis. This gets back to what Sherbino was talking about in traumatic cardiac arrest, that in a situation that complicated, applying a purely scripted algorithm is going to get you in trouble. But if you're thoughtful about what you deem to be the physiologic priorities and then address those in a stepwise fashion, you're much more likely to stay out of trouble.
And I think, we try and present that using a case where a patient is clearly in shock. It appears that they have at least a component of hemorrhagic shock, as well as pneumothorax. And in the first iteration and the first sort of what we call case 1.1, using the traditional approach, we show the patient's deterioration immediately after intubation, as this was the priority by the team following the traditional ATLS approach. We then resequence this and articulate to the reader how, using what we think is a more physiologically appropriate approach, we focus on getting blood into the patient, we focus on decompression of the chest, initial resuscitation while providing the necessary oxygenation, and then moving to intubation only once things have stabilized, acknowledging that you have somebody right at the head of the bed watching for any change in the airway that would mandate immediate definitive airway management. And we use our algorithm or our proposed approach to articulate how we think the care of this patient would change from a usual approach that is often employed around the world following the traditional ATLS teaching.
Since we're already talking about airway management, I'd like to move to the Airway Management in Trauma article. Can you talk a bit about the main points of this article by Dr. Kovacs and Dr. Sowers?
So if you don't know George Kovacs, he's an emergency medicine and airway legend, not just in Canada, but around the world. And he runs he is one of the organizers and operators of a difficult airway course, which is very well attended throughout Canada and I think also throughout the world, and does a cadaveric airway course as well. And so we went to him quite deliberately with this, really because, again, like traumatic cardiac arrest, the tools available for airway management and trauma are known to anyone who practices trauma. Most people could tell you the 4 or 5 approaches that they have to managing an airway in a given situation. What we wanted to get from George then was not just tools, but sort of his experiential understanding of what airway management should like, almost a philosophy of how to approach airway in trauma. In addition to, his fairly remarkable background in terms of technical expertise and experience. And we really wanted him to, he did do this for us. He gave us quite a brain dump of information, I think based a lot on his his long career and sort of deep understanding of airway management. I think when the readers look at that article, that's what's going to shine through, is that you're dealing with authors on that paper that have a pretty remarkable depth of understanding of airway. And I think the other thing that should jump out at readers is neither of the people that wrote that paper are anesthesiologists. That's not to knock the importance of anesthesia in trauma management and in trauma airway management in particular. I think it's just nice to acknowledge that trauma is very much a team sport. And in particular, airway management in trauma is a real team sport. And so it was really nice to be able to bring an emergency physician with such depth of expertise in airway in as the senior author for an article that deals primarily with airway management.
So we're coming to the end of our time. Any final thoughts that you'd like to express on the issue as a whole?
When we approached this, we went after writing teams by way of identifying senior authors that we knew and respected in trauma care, both throughout North America and Europe and Australia and a bit beyond that. And we really contacted, I think what Andrew and I would agree would be our dream team of senior authors. And almost to a person, everyone said yes, which blew us away and actually made us, in some circumstances, feel a little uncomfortable editing some people who, are clearly international experts in their field. But I think the result is, if you look at the writing teams and the people on them and the people that contributed to the series, there is a remarkable depth of experience and knowledge behind each and every chapter. And although I've been doing trauma for a while now, every article I read, I learned a ton from. And in addition to that, as we sort of alluded to with the human factors paper, we did not want to write a series that just said, okay, head injuries, here's the epidemiology, here is the cost of care, here's what we know, here are our recommendations. We wanted specifically to avoid that sort of writing. We wanted articles that explored issues that were of practical importance to emergency medicine physicians. Nobody really in emergency medicine cares too much about the epidemiology of head injuries, although that's irrelevant. It's not that relevant to practice. We really wanted to focus on two things, I think, and this is what we asked the writing teams to do, and I think this is what they did so successfully. We wanted them to particularly explore areas of controversy, the things that come up in clinical practice that are a challenge, and trying to offer people an approach to managing it. So sticking with head injury, how do you manage a head injured patient who's also bleeding, for example? And there's a huge conundrum there about what sort of a blood pressure do you target and how aggressively you do resuscitate that patient. That's a practical challenge that comes up all the time, and there's no great solution to it, but we wanted our experts to bring their knowledge and experience to help EM providers address those problems in their practice. And then the second part is we really wanted to be forward-thinking. We didn't necessarily want to talk just about what trauma care looks like now, but what trauma care is going to look like in the next 5 to 10 years and perhaps beyond that, the sort of state of the art of trauma care. So, trauma care now might, for intra-abdominal hemorrhage, involve a patient who gets aggressively resuscitated and sent to the OR. And in 5 years from now, those patients might be getting Roboa catheters put up in zone 1 in their abdominal aorta as a matter of routine. And that's one of the things that Megan Brenner spoke to. She's a trauma surgeon from Baltimore, who's an innovator in Roboa care. So we really wanted to make sure that we were trying to be forward-thinking as well, and all of our authors did a fantastic job of that, not only speaking to controversies in contemporary care, but also saying, well, where are things going to go, and what sort of cutting-edge issues should an EM provider today be aware of, and how is that likely to influence their practice moving forward?
And I think when you look at each chapter, and Chris has already sort of laid this out, that we were very clear with the authors that we wanted important clinical questions, clinically relevant questions answered. And if they couldn't provide an answer, that would be fine. And certainly there were many times when that was the case, but they would outline a reasonable approach. And you can see through each edition, each chapter, it's laid out in a way that if you as a reader are going through it, you can quickly peruse the first line of each section and understand quickly what it's going to be discussing. And this, we think, makes sense to the way that emergency medicine providers think. They just need quick answers to questions or a quick overview of how to approach this. And we also asked authors to put in, when the evidence was missing or when there's a lack of evidence, their own approach. And I think we got some really great ideas, and we heard from a ton of experts with how they care for patients. They were very explicit. There's a lack of evidence for whatever topic it might be, but this is how we do it. And I think that really is valuable for people who don't take care of trauma patients very often, and they can actually hear exactly what it is that people do, rather than when we read textbooks and they simply outline, here are the ideal situations, and here's how the ideal way of doing it. But we tried to make this relevant and applicable for the reader.
Right. It's always frustrating to read an article, something other than a research article. It says, well, there's conflicting evidence or no evidence for intervention X, Y, or Z, and therefore, who knows? And disappointingly, that's where the recommendation might end. So as Andrew pointed out, we wanted people to say, well, given the lack of evidence or equipoise, what do? You expert in trauma for 20 years, what do you do? And speak to that specifically as your experience, so people know that that's what you're talking about. And again, as Petra's already identified, I learned a ton from reading a lot of those recommendations, just getting into the heads of trauma experts and seeing how they think about complicated problems for which there are often no easy answers.
Wonderful. Well, we'd like to thank you both very much for your thoughtful insights and for taking the time to speak with us about this incredibly important issue. It's been a pleasure. Thank you for joining us for this edition of the Emergency Medicine Clinics podcast. For an exclusive discount on the issue we discussed today, focusing on damage control, advances in trauma resuscitation, visit us.elsevierhealth.com/EMC podcast. Emergency Medicine Clinics is available for individual print subscription with accompanying electronic access and can be accessed on the Elsevier electronic platforms, Clinical Key and Science Direct. A CME program is also available. For more information, visit info.theclinics.com. Be sure to follow us on Twitter at eMedClinics and subscribe to the Emergency Medicine Clinics podcast on iTunes. Recent issues of Emergency Medicine Clinics have focused on wilderness and environmental medicine, observation medicine, and vascular disasters.